This episode is brought to you by Liquid IV. When you hydrate with Liquid IV, you're powered by Hydroscience. Hydroscience is Liquid IV's science-backed formula with an optimized ratio of electrolytes, vitamins, and nutrients. Experience great-tasting hydration for mental clarity, physical endurance, and overall well-being. Sip into something that up-levels every moment. Liquid IV. Tear, pour, live more. Visit us at liquidiv.com.
Hey, business owners, we know you know the importance of maximizing every dollar. With the Delta SkyMiles Reserve Business American Express card, you can make your expenses work just as hard as you. From afternoon coffee runs to stocking office supplies and even team dinners, you can earn miles on all your business expenses. Plus, you can earn 110,000 bonus miles for a limited time through July 16th. The Delta SkyMiles Reserve Business Card. If you travel, you know. Minimum spending requirements and terms apply. Offer ends 7/16/25.
Hi, everybody. Welcome to the Dr. Psych Mom Show. And I have an awesome treat. This is a special guest, Dr. Christine Vaccaro, and she is a urogynecologist and a sexual medicine specialist. Is that right?
That's correct.
Right. Awesome. And she practices via telehealth. So I'm going to have all of her information in my podcast description so that you can contact her, because she is a wonderful resource. She does so much. You do research, you're always at conferences, and you do clinical work, correct?
Correct.
Yeah, and you're always presenting and like doing all these things. She's on Instagram, so I'll have that link as well. And the reason that I wanted to have her on, aside from that she's awesome, is that everybody asks me about sexual issues because I work with couples and I work with a lot of women in perimenopause and menopause. So is this a lot of the women that you see are in the perimenopause age? Christine?
It is our niche practice. I practice in Bethesda, Maryland, and our practice is kind of known for menopause, midlife, women's health issues, which include pelvic floor issues as well. So just if you're wondering what a urogynecologist does, I see patients for any quality of life problem, including urinary issues, bowel issues, vaginal support issues, sexual pain issues, and then disorders of arousal, libido, orgasm, as well as menopause hormone therapies, which is a completely, I'll just say midlife women's health issues right now in the U.S. are not well taken care of. So it's a special area of focus for me and my practice.
Yeah, that's awesome. And so many people don't have any idea who to go to. So if they have sexual issues, so a lot of people in my practice will say that they just speak to their GP. And then their GP often says, well, you're just getting older, and that's what that is. Or they'll do the cursory blood work and they'll say, looks fine,
Yeah.
and then the woman is kind of left at loose ends. So when somebody comes to you then and says, let's say the most common thing that I hear about is I don't have any sex drive anymore.
Mm-hmm.
All right. So then somebody comes in and says that to you. Where do you go from there?
Yeah, I love this question because there's a whole, I'm sure there's the biopsychosocial model of libido. So my specialty and forte is the biology side. So how do the hormones, neurotransmitters, sexual pain, body image issues, whatever the issue is, how do I help the patient from a biology side? But then there's also your side, right? There's the psychosocial factors, which are also massively important.
Yes.
If a patient doesn't like her partner, or she's struggling with aging parents or difficult children, et cetera, financial issues, like all of the things fall into libido. But I would say by and far, most women in midlife, and that's anywhere from like mid 30s to mid 50s, have significant hormonal changes that really make them not want to have sex. I mean, it is literally hormones are messengers for our brain, and libido is a feeling. And we don't get the right signals in the brain, it just doesn't sound good. It doesn't sound appealing. Women, a lot of times that I know, they feel like they have to have duty sex to keep their marriage alive, et cetera, et cetera. So a lot of women come to me, they feel broken. They feel like they used to want to have sex and now they don't. And now it's like this partner mismatch and the husband's threatening divorce. And it's just like this whole big issue. And then again, there's like other sexual pain disorders that are a whole separate issue. If a woman's having significant sexual pain, let's say she's even younger, not in midlife, but she has pain with penetration, I kind of equate that to like, well, would you want to put your hand on a hot stove every day? Like, no, I don't want to put my hand on the hot stove every day. Like it doesn't sound enjoyable. So the libido is basically due to a pain issue. If we can fix the pain issue, a lot of times with some mindfulness and retraining, a woman can regain her libido if it's due to just a pain issue. So there's so many things.
Like once you get rid of the pain, then she's still scared because she still has PTSD, basically.
Correct. It's still that association that even though we fix the pain, it's like the body needs to be kind of like the nerves just need to be reorganized, right? So that they don't associate it with a pain anymore. And
is that kind of like exposure therapy? Is that impressive?
It can be. I do a lot of, we have wonderful sex therapists in our area. We sometimes send them to those folks. Sometimes they need pelvic floor physical therapy just to help literally do dilator therapy to retrain their body that this is not going to hurt anymore. Yeah. So every patient's a little bit different, but there's so many, there's literally so many different diagnoses that play into low libido that contribute to low libido. But I would say by and far, the most prevalent is just change in hormones. Perimenopause is a roller coaster of high estrogen followed by extremely low estrogen, and that feels really, really bad. So when women are having, more mental health issues because of hormone changes, so anxiety, depression are really common in perimenopause. Sleep disturbances, poor sleep, waking up for no reason. So when women are feeling like completely fatigued, the last thing the body wants to do is engage in sex. It's just like, I don't want to do that. I can barely function. Like the last thing I want to do is have sex. I'm so fatigued. So poor sleep, again, especially in perimenopause, contributes. And then there's, all sorts of, call them rude things that happen. The menopause belly, so losing muscle and gaining fat, usually around the midsection, that contributes to body image issues. And then a woman's just like, I just don't feel good in my body anymore. And that makes me feel unsexy. And then I don't want to have sex. So there's literally all these
different factors.
It's like death by a million paper cuts, like sort of in perimenopause. Then they start leaking urine, and then UTIs start happening. And then they associate UTIs with sex because sex can be a trigger for someone for UTIs and in midlife.
So many questions. I'm not going to be able to do it all in an hour. Okay, so let's just start with just straight up. You just said the estrogen, it gets up and then down. And what about testosterone? Because that's a really big one, and women do say, at least in my practice, that can be a big change when you start using testosterone cream or pellets or anything. So explain that to me.
Yeah. So testosterone is a really important human hormone. It does not just belong to men. And in fact, women have more testosterone at all times in our lives than estrogen. I think that is way misunderstood. Men, of course, have a lot more than women. So it's thought to be a male hormone, but we've genderized hormones like estrogens for women, testosterone for men, but that's not true. Men actually have more estrogen than women after menopause. So again, these are just human hormones. We just have very
and I have as much testosterone as my 11-year-old son. He's on his way up and I'm going down.
Totally.
We over.
Absolutely. That's so funny. Yes, that is true. So the interesting thing about testosterone in both men and women is it really slowly starts declining in the late 20s.
Wow.
Okay? And then it takes a huge nosedive in the late 30s. Okay. And then that's going crazy down. And then here comes perimenopause with crazy fluctuations of hormones. And we have testosterone declining. And then we have crazy ups and downs with the poor sleep and the hot flashes and night sweats. And now we're getting vaginal dryness and sexual pain. And it just is a really cluster of rude symptoms for women, really rude, what's going on. And a lot of women, it's hard for them to connect all the dots because, they might not associate certain symptoms with these changes. And again, low libidos, because it's biopsychosocial, can be so many factors. But again, midlife, late 30s to mid 50s is kind of where these symptoms start popping up. And testosterone, in addition to estrogen and progesterone, can be really helpful for libido. I mean, testosterone is thought of as more the libido hormone in men and women. So oftentimes in my practice, we are supplementing with testosterone in the female zone for, keeping women in the female zone, just kind of more in that like 20 to 30 year range versus the, 50 and above range. Because that's again.
What about side effects? Because so many women are very anxious about that.
Yeah. When we keep women in the female zone, they shouldn't really have any side effects. But I would say, just like when women go through puberty and acne happens because of a huge increase in testosterone, which happens to boys and girls. That's why acne happens in the teenage years. When you start on testosterone therapy, you can get oilier skin, which then can clog your pores and create acne. It's usually just like puberty, very, very transient. And again, when you're doing testosterone therapy, usually it's much more mild, like a pimple or two. But, if women aren't prepared to know that they might have a return of pimples briefly, they need to be at least told that might happen.
Yeah, and I've heard about bloat and irritability and that kind of thing.
It generally doesn't cause mood changes other than, again, more feelings of overall well-being. And actually in men, my partners are urologists. They do a lot of testosterone therapy for men. And men, oftentimes it helps their mood because low testosterone is linked to depression and amotivation, basically, in men and women.
What about these guys that I see that are in their 50s and they're getting their testosterone up to like 1,000 or something?
Okay, well, that's even super physiologic for male range, right? Male range is usually up to 800. So, if they're getting way above the male range, that can cause rage, anger. I mean, that's not physiologic though. So
what you're saying is as long as somebody does it within normal limits and under the care of a physician, and I assume you need blood tests to see how things are going?
Yes. So testosterone is one that we have clinical practice guidelines, international clinical practice guidelines that say that we need to check a baseline to make sure we're low.
Right.
We don't need to do this for menopause hormone therapy, by the way, but for testosterone, that's the guidelines. So I follow the guidelines. Make sure they're low, and then also make sure we're keeping them in the female range.
Yes.
Because again, we're not trying to change a woman right into a man. That's not the purpose. The purpose is just to get them back feeling more like themselves into the female range of testosterone.
I know. What about the vaginal dryness stuff? Because that's another huge issue for women. Obviously, like lube does something, but then women feel like they have no kind of internal.
Yeah.
Yeah.
Absolutely. This is a huge issue. And sometimes I think it's physicians even downplay it like as a little vaginal dryness, but this can be like, again, devastating. It can ruin marriages. A $13 tube of estrogen cream can save marriages because, again, if a woman feels like there's razor blades cutting her when she's having penetration, that's not going to bode well for intimacy for the couple. So giving back vaginal hormones, usually in the form of vaginal estrogen, but we have other tools as well. But usually the mainstay is vaginal estrogen, which is safe in every woman, even women that have a history of breast cancer. So, and we had just so much data to support the safety and efficacy of vaginal estrogen. And it not only decreases dryness, but also helps on the urinary system. So decreases urgency of urination, decreases recurrent UTIs. So there's so many benefits of this really simple and very inexpensive local therapy.
Why do women get more UTIs as they get older with sex?
Yeah. So the pH of the vagina should be under 4.5, which is a very acidic pH. It's kind of one of the more acidic places in the body, other than the stomach. The stomach is also very acidic. And the reason it's very acidic is so that we keep out the bad bacteria because, the anus is, right next door. And that has some different kind of bacteria, usually E. coli, which is a really common UTI bacteria. So if we can keep the vaginal pH really acidic, then bad bacteria like E. coli cannot live in and around the vagina because the vagina and urethra are very close next door neighbors. So vaginal estrogen makes the top layer of the vaginal skin really healthy and plump. And the lactobacilli, which are healthy bacteria that live in the vagina, produce lactic acid from these really healthy cells. And they feed on these healthy cells. And it's kind of like a symbiotic relationship that keep those really, really good bacteria there to keep out the bad guys and keep a really highly acidic environment. When estrogen goes away, those really fluffy, healthy cells go away too. And then there's nothing for those good, healthy bacteria to feed on, and then they die.
Oh.
So vaginal estrogen is really like the infrastructure to support a healthy microbiome. Oftentimes women are, using probiotics or doing other things, lubricants, moisturizers, and those are all really effective in some form or fashion, but without vaginal estrogen to kind of give that, again, supporting healthy lining, they're called epithelial cells. Without those epithelial cells there, we can't really change the vagina much as far as pH goes.
And so then with anorgasmia, so then when women can't have an orgasm, what is the go-to? Is it this same moderating the hormone stuff?
Yeah, so orgasm is also biopsychosocial, so many things that play into that. But if, let's just say, hypothetically, that a woman had normal orgasms leading up to menopause and then lost her orgasm.
Yes.
Which is really common. Most of the time, this is due to blood flow issues. So if you think about men, right, who have erections, it's really easy to see when things change, right? Because they have a visible outward sign. For women, it's harder to see because we don't have, a penis. We have a clitoris, and the clitoris doesn't, is not as big or prominent. So we can't really see changes in blood flow as well to the female genitals. But we know that the blood flow is changing. And when blood flow changes, orgasms tend to get less intense. They tend to become more difficult to achieve. A lot of women have to, stimulate for a very long time, and I'm talking about the clitoris. Stimulate the clitoris a really long time, and most women that get frustrated also. And it's not wrong. I love sex tools, but some women have to only use sex tools at a certain point because that's the only way they can orgasm, and that's been a change for them. So again, I'm a huge sex tool advocate. I just there's a paper coming out next month in a prominent GYN journal about that I authored on sex tools. So I'm a huge proponent. But if that's a change and that's bothersome, oftentimes when we do an exam, and this isn't common knowledge, but women can get clitoral adhesions. So not only do the genitals have changes in blood flow, but the hood of the clitoris, just like the foreskin of a penis, they're the same embryologic structures. It can fuse over the clitoral glands, making it really difficult to stimulate the clitoris. And when you can't stimulate the part that feels really good, it's really hard to achieve orgasm. So
it happens in later life. You can get a clitoral adhesion.
Yes, and
it happens in perimenopause and menopause.
It happens at any point in a woman's life, but we find that it happens a little bit more in perimenopause, menopause, again, due to blood flow changes.
No kidding.
Yeah. So
I've never heard of.
We could do a whole thing on that because I think it's absolutely fascinating. It's physicians aren't really taught, even gynecologists, about the clitoris. It was only in medical textbooks a couple decades ago. The first publication was in 2005 on the clitoris. So we're very far behind in female genital anatomy.
That during a regular exam, they don't look at the clitoris. At least
they do not.
Right?
Yeah, because
I'm not missing something.
Because medicine doesn't prioritize female pleasure, right? We prioritize, is it painful? Can you get pregnant? And you're kind of looked at as a reproductive thing, right? You're not looked at as let's make sure you're having good pleasure. So it's a disconnect, which is different than men, right? If a man goes into a urologist with a kidney stone, it's kind of a joke, but they usually leave with Viagra. Like they go in for one thing, and it's like, how are your erections? We need to help you in this department. Like it's normalized, right, to make sure that men feel that their erections and their performance is good, but a woman never, unless she's having a pain issue, it's never like, well, how's your sexual pleasure? Like, how are you feeling? Is anything changed? Are your orgasms different? You're having any dryness issues? Like,
I've never been asked. Nobody said to me the word orgasm in a medical component setting in my whole life.
You haven't seen me, but but that's basically
friends that have seen you. So everybody go to Dr. Christine Vaccaro. But anyway, continue. So you would go to a regular OBGYN thing. You would get your pap smear because that's what we do as women. Right. Unless we're going to see a specialist like you get in, you get out. The pap smear takes, 30 seconds. There's you feel a little bit of pressure, and then you do it with a big Q-tip, and then you're done. Nobody's circling your clitoris.
No, And
you know.
And Samantha, the crazy thing is, when a patient comes in saying like, which is rare, but a patient's like, you know what, something's wrong. I know something's wrong. I can't stimulate. It doesn't feel good. Most gynecologists, sadly, and I'm a gynecologist, most gynecologists don't even know what normal looks like because they don't ever examine it. So it's like well, I don't know, so it's this like very much, we haven't been taught well in our education about this anatomy. And so we're not doing a good job at disseminating this information. So I'm really trying hard, and my colleagues are trying hard. We actually just submitted a video to my national organization, the American Urogynecologic Society, on a video about clitoral adhesions and how you take care of them, how you diagnose and treat them. So hopefully, again, just like
surgery.
What's that?
Surgery takes off a clitoral adhesion.
It's an in-office procedure. You can do it in an operating room setting, but it doesn't need to be. It can be done in an office. Yeah.
Okay.
But but I think
women don't even know what their clitoris looks like or anything.
How many times do people look with a mirror? I mean, that's
right.
Also the thing, right? Women aren't ever given permission just to look at their own genitals. It's like, it's a part of your body. It's like your elbow. Like, you should feel comfortable looking at it and knowing what it looks like, and also knowing if things are changing, and what it looked like before and now what it looks like now. So in our practice, we literally give women a mirror and we look together so that women know their body.
My dentist does that with flossing.
There you go. It's just another orifice. It's fine, right?
But there are a lot of women that I work with that have been raised to be very sex negative, and men, by the way, too. And, your parents think that sex is dirty. You're not supposed to masturbate. You're not really supposed to have sex before marriage. And so then the idea of knowing what a baseline is, like in your 20s, these women are having very bad sex, like whether it's before or afterwards, they don't know anything about their bodies. I mean, I remember when I was young, when I was a teenager, I was reading, Cosmo or 17, something. One of them said, your cervix should feel like the tip of a nose. So put your finger into your vagina and feel your cervix. And I read it. I was close to my grandmother, and she was born in Poland in 1910. And I said to her, did you ever feel your cervix? And she said, why would I do that? She was just like so shocked. But it's just dependent on how you're raised, how you think about things. I don't think that many women could identify their own clitoris from a lineup of pictures, So what you're basically saying is that if women are interested in their sex lives and interested in having more pleasure, whether it's just for themselves or for the marriage as a whole, you would recommend that they get more familiar with their bodies and go to a practitioner who is comfortable talking about things like this, correct?
Absolutely. And again, it seems daunting, but it's really not. It's just a mirror, and it's just exploring and looking. And there's a wonderful society called ISWISH, the International Society of the Study of Women's Sexual Health. It has a lot of wonderful online resources just to look at other anatomic illustrations. I'm in another sexual health nonprofit organization called She Plus, which stands for Sexual Health Education Plus Foundation.org. And we have a lot of resources as well, Sexual Anatomy 101. But the bottom line is look at your genitals. You have my permission if you need it. You don't need my permission, but sometimes women just feel like they need permission to exert themselves, either whether that's just with a mirror or sexual stimulation, masturbation. There's another wonderful online resource that I recommend all the time called OMGYes.
I knew you were going to say it. That one.
Yeah. Yes. So good.
OMGYes, right?
Yes. Yeah. It's really tasteful videos for women to help them teach themselves about how to explore. Again, there's so many women that have never had an orgasm, like 10 to 11% of women. Never.
Yep.
So that's,
at my practice videos, we have a sexologist on my practice, Heather Ray, and we did videos on female arousal, partner's guide to female pleasure, lick it right for oral sex, blow his mind for male sex. But the one of the things too is that women, as they get older, they need more foreplay because the whole system doesn't kick in
as
like
fast. Yeah.
it used to. And that's a big thing that I talk about. And guys, and the women, they just don't understand why he can't just like roll over and stick it in anymore. And it's like, he can't,
Yeah.
probably would have been better if he never was, but
Right.
certainly can't as things change,
Right.
It's just a different, sex has to evolve as you get older,
For sure. It absolutely does. And learning your partner and adapting to different changes. Again, I love that you said that, foreplay needs longer. Foreplay should be super fun. It should be like, again, it's like the journey, not the destination. It's like eating a nice meal. Like I'd rather sit down to a several course meal than just, although I love dessert, than just go straight to dessert. Like it's just like enjoy the process. Don't be focused on just one outcome. But for women that have never had an orgasm, I think it's very frustrating. They think they're broken. They think something's wrong with them. They, wonder. They'll tell me things like, "I think maybe this one time I felt something." And whenever they're saying that, it's pretty clear that they probably have not experienced orgasm. It's a pretty definitive whole body. It's almost like a seizure happening in your brain kind of experience. And every woman should have that experience in her lifetime. So we have lots of tools to help women. And I'm sure there's so many meds on the market.
What about Cialis for women? I've heard of that.
Yeah. So again, if you think about blood flow, right? So again, for men, this is used for erectile dysfunction, improving blood flow. For women, we don't have as much great data because again, we can't see erections in women. So but we do know it's a blood flow issue. For some women, it fixes their arousal and their orgasm issues. I would say for most women, though, that's not where I would start. I would start by looking for adhesions, replacing the hormones to the genitals first to encourage natural blood flow. But if those things don't work, then certainly Cialis, and either there's compounded ways we can give Cialis as well. Sometimes are beneficial, but I would definitely wouldn't be my first place to start, but it's certainly on the menu of options.
Now, what about when people are taking SSRIs and that lowers libido and you can't get an orgasm?
Yeah.
What do you do then?
I would say the two big categories of medications that really hinder libido and orgasm are SSRIs, so that's like Celexa, Lexapro, Paxil, Prozac. Zoloft, thank you. I'm forgetting some. But that whole category, when it pluses up so much serotonin, serotonin negatively impacts libido by downplaying norepinephrine and downplaying dopamine, which are our major neurotransmitters that help with libido and help with orgasm. So it's a super common side effect of SSRIs. Mental health is a significant issue in our country, and there's so many ways to treat it, not just with SSRIs. There's other medications that are non-SSRIs that can be used.
DRIs, like Wellbutrin, right?
Exactly, that don't have those negative sexual side effects. So, I hate in medicine that sometimes we treat one problem and then we create another. So it's like, okay, now we fixed the depression, but now the couple's struggling because she's not having any libido and her orgasms went away. And now we've created this other problem. So we can counteract SSRIs with another medication for libido called flibanserin or Addy. So that kind of helps plus up the dopamine norepinephrine. So it kind of helps like rebalance the neurotransmitters. So that's sometimes an option that we have if we can't switch
that's
to one.
That's that ADDYI thing that I've seen advertised. Addy.
Yeah, Addy. Yeah. Okay. So that's a way that we can help kind of rebalance those neurotransmitters if a woman can't come off of the SSRI. And then the whole other category of meds that really kill and crush a woman's libido are oral contraceptive pills. So the birth control pill, for a lot of women, makes them feel sexually free, which is a libido booster. But for a lot of women, it decreases testosterone. So that's a libido killer for a lot of women. So women often tell me like my libido went away or my orgasm even went away with oral contraceptive pills. And then when I got off those, it returned. So sometimes that can be something to play with. There's so many non-hormonal birth control options that are so great. And there's also non-systemic birth control like IUDs that don't have those same side effects. So, pregnancy prevention is obviously really important, and feeling sexually free and not getting pregnant, really important for libido. But there's so many ways that we can do that don't alter a woman's hormones.
What are some of the ones that people don't usually know about?
I think one that is really uncommon, but I love so much, is called Phexxi, Phexxi. It's an on-demand lactic acid gel. So think about like a spermicide on steroids. It's injected just like just an applicator in the vagina right before penetration, and it's really effective and also supports the health of the vagina. So for women that are having like recurrent, BV infections due to sex, because again, ejaculate is basic. The vagina is acidic. You put the two together, and for women that have sensitive
Never
pH,
heard of that in my life. When did they come up with that? Phexxi.
it's been out a few. It's been out a few years.
Wow.
Yeah, at least 10 years. So it's a nice adjunct in obviously monogamous partners that aren't needing, STI protection with condoms. So it's a nice on-demand method, non-hormonal. Another one that's really cool is, because people love tech these days, is the Oura Ring. The Oura Ring has an FDA-approved app called Natural Cycles. So the Oura Ring tracks the temperature, which ovulation occurs.
It's my tech rhythm method, right?
Yeah, so it basically tracks out your cycle and then also gives some bio data, meaning like your body temperature, and tells you when you're in your fertile window and tells you when you're not. So it's as effective as a condom for pregnancy prevention. So those are like
because you don't have sex when you're ovulating is the point.
Or you use a condom.
Use a condom when you're ovulating.
Yeah.
See, that is what I always say, is that the guy should use a condom. I mean, seriously, that is, if she doesn't want any hormones and she doesn't know about Phexxi, or she doesn't like Phexxi or whatever, I don't really get what the problem is. I'll tell you, and this is just a little tangent for 1 second about people that I see, is if the guy has that much of a problem with the condom, there's other stuff going on there that makes him kind of a difficult person, because you don't need the condom all the time. After she's ovulated, you don't need the condom in the luteal phase. You don't need the condom, which is, I mean, I'm sure people will be like 99 per whatever, but the point is, if you can't use a condom a couple times a month, and most of my guys only having sex a couple times a month, I mean, that's an aside and a parenthetical, is I'm a big proponent of that.
I 100% agree. And then there's also vasectomy, which is like the most effective birth control for men and women other than hysterectomy. I mean, it's literally snip, in and out. And that's a really wonderful birth control method. But again, back to the patients that get recurrent BV.
I love how I don't have that skill. It must be an MD skill to stay on track like you do. You brought the conversation back a couple times, and I'm like way everywhere. But yes, to get back to it,
because this is another huge issue. These women that get in these recurrent BV yeast cycles, or recurrent UTIs, and then they get an antibiotic, and then they get yeast, and then they get BV, and I'm telling you, it wreaks havoc on them. They're constantly fighting odor issues.
They're scared of sex, the women that have it.
It's really frustrating. So for those patients, back to the condom idea again, and ejaculate being basic, if a guy just wraps it up so that there's no ejaculate in the vagina, that can also really help her vaginal pH, so that she doesn't get a dysbiosis. Or, alternatively, if there's another good form of contraception on board, then again, just not ejaculating in her vagina would also be fine, right?
Yeah.
The less.
And I'm not an MD, but I just prescribed that to somebody this week that said that the woman had recurrent UTIs. I was like, from sex. And I was like, do you use a condom? Everyone's like, well, why would I use a condom? I'm like, why wouldn't you use a condom? Then you're physiologically, you're not having sex. You're both in hazmat suits, and she can't possibly impact her, right? So try that. That's what I think.
And I think it works really well for the prevention of bacterial vaginosis. It does not work so well for UTIs, because if you think about what's happening with sex, there's just a lot of transfer of bacteria in and around the area. So even if the guy's wearing a condom, her own bacteria are getting transferred, if that makes sense. So there's a lot going on in sex, and there's a lot of friction, right, on the vagina, which causes a little bit of inflammation. I'm not
Those
really
are the
sure.
micro tears,
Yeah,
tears.
like little just inflammation, micro trauma to the tissue again. So the just act of sex is a risk factor for UTI, even if it's with a condom. So there's so many ways that we can treat that as well. But again, the baseline is always like making sure we have vaginal hormones on board, especially if women are anywhere in the midlife, because
Yeah.
that's generally a huge player.
And now, overall, as women get older, I have heard of people who stabilize their hormones, that their provider puts them on birth control because of perimenopause. But in perimenopause, you lose your libido. So that would seem like not the
Yeah.
best.
It's not the best. It is an option, right?
Uh-huh.
Because in perimenopause, it's certainly possible to get pregnant. So if there's no other form of pregnancy prevention, it certainly can mitigate hot flashes, night sweats, and prevent pregnancy. So it's not wrong, but it's certainly not like as elegant as hormone replacement therapy and using another form of contraception. So that way, hormone therapy is just supporting your natural hormones, estradiol and progesterone, and not decreasing your, estrogen and progesterone, and not decreasing your testosterone. So it's a nicer, elegant way to support the body versus birth control pills. Birth control pills are a super high amount of synthetic hormones that bind very tightly to the estrogen receptor to shut the system down. Okay, and when there's so much circulating hormone around, the liver makes a binding globulin called sex hormone binding globulin that gobbles up all the extra sex steroids, including testosterone. So that's how birth control pills really negatively impact libido, right? There's too much circulating hormone, sex hormone binding globulin. Think of like a Pac-Man just out there chewing up all extra estrogens and testosterones, and that just plummets libido. So and also birth control pills have a much higher blood clot risk, meaning, clots in the legs or clots in the lungs, even stroke is possible, than hormone replacement therapy. So transdermal hormone replacement therapy in the form of estradiol has zero risk of blood clots.
Transdermal means the cream, right? Going in through the skin.
Yeah, transdermal, like a patch, or like for whole body support, not just the genitals, but like literally a whole body support for hormone therapy. So again, just to break it down, the birth control pill, if you need pregnancy prevention and you're having crushing hot flashes, is not wrong. It can treat both of those things, but it's going to potentially lower libido and be at a higher blood clot risk. Versus if we use non-hormonal therapies or non-systemic therapies like IUDs for birth control, and then give back a woman's natural estradiol and progesterone, which is the same molecules her body, her ovaries were making, just not making enough of anymore. It's a better way to support the body.
Women have had like a cancer history, like breast cancer, ovarian cancer. Then how do your recommendations change?
So that's a long conversation with the patient. But to break it down easily, ovarian cancer is not a hormone sensitive cancer. So ovarian cancer by itself is a non-issue for hormone therapies. But breast cancer, because the breasts are really sensitive and have a ton of estrogen and progesterone receptors in the breast tissue, then we have to have a long conversation about her risks and what that's going to do. So most providers will start with non-hormone therapies, and there's literally a pill for every single menopause symptom that's non-hormonal. There's one for hot flashes called Bethesda. There's a lot of off-label medications for hot flashes that are non-hormonal. So there's tons that we can do.
What does it work on then? What does it work on if it's non-hormonal for hot flashes?
Yeah, it works on the candy neurons in the brain, which are kind of part of the temperature regulation in the brain to help regulate that. But it's not perfect. None of these anything that's a medication is going to have a potential side effect versus hormones, which I would argue, are not even medications. They're just natural substances our body produces, like thyroid gland produces thyroid, right? They're just natural substances. They're not going to have as many side effects. So Bethesda, which is the one for hot flashes, there's a significant risk of liver toxicity. So a woman has to get her labs drawn every month after starting to take it, just to make sure she's not going to get that condition. And it only works about on average 50% of hot flashes. So it does reduce hot flashes by about 50%, which is good. But with hormone therapy, we can actually get it to 0. So,
Yeah.
and then hormone therapy also works for mood, and it works for your joints, and it works for your bones to support your bones. And so again, it kind of supports the whole body. But back to your question, we can give a pill for depression. We can give a pill for hot flashes. We can give a pill for joint aches and pains. We can give a pill for overactive bladder. We can give a pill to support the bones. Like we can give eye drops for dry eyes. Like we can treat every symptom with a medication. It's just now you're taking a lot of medications, to treat each thing versus essentially using what your body was naturally doing to support your whole body, which would have been.
How long can you keep taking hormones? Because sometimes I hear you got to stop after X years past menopause or something.
Yeah. So that was like an older style thinking, which came out from a study over 20 years ago called the Women's Health Initiative, where they basically, and other guidance said, if you're really suffering, women had to prove they were really suffering and they were given hormone therapy, they only wanted them to be on the shortest duration at the lowest dose. That was the guidance. And that, really, really strongly consider stopping by the age of 60. That whole idea and that style of thinking has been gone by the wayside. And now we really want to continue hormone therapies lifelong to support a woman, because as soon as we take them off hormone therapy, then we start losing bone mass again. We start losing muscle mass. Our brain starts changing. Our cardiovascular system starts changing. So when I think about hormone therapy, I really associate that 1-for-1 for prevention of disease, right? We can use hormone therapy to prevent, it's actually FDA approved to prevent osteoporosis. We can use hormone therapy to prevent disease, but once disease happens, let's just say it's osteoporosis, we can't totally reverse that, right? Hormones don't treat disease, but they can prevent disease, if that's helpful to think about. So not only for women that are having crushing symptoms of hot flashes, night sweats, other libido changes, but also just osteoporosis prevention is a huge thing that doesn't have any symptoms until you get a terrible fracture. Just trying to think about a woman's lifespan, right? Most women live several decades after menopause. We want them to live their best quality life and also prevent disease for as long as possible so they can maintain, functionality.
So what about energy when the energy tanks?
So energy, again, is one of those like multifactorial things that I start when I think about energy. I first ask about sleep, and I get a really detailed sleep history. Most women in midlife or later are not getting adequate sleep for a variety of reasons. So really we focus on sleep, and then I focus on nutrition and exercise. And then again, we're also at the same time talking about the benefits of hormone therapies to be able to support their sleep, and then getting them hopefully back in to the gym to do weight training. Because again, getting strong is really important for fatigue prevention, but also just, functionality lifelong. It's kind of like muscles are like the organ of longevity. So we need to make sure that women are strong.
Yeah.
Going forward.
When you see a woman that comes into you and her husband wanted to sit in the session with her consent, is that something that you see a lot? So you could explain these things to both?
All the time.
Yeah.
Especially the couples that are having sexual pain issues, because I find it helpful, and usually the patient finds it helpful for me to explain what is happening, to normalize it, and to help them understand that it's not that she doesn't want to have sex, it's that she has this very common sexual pain disorder that is the cause, and here's how we're going to treat it and lay out like the path forward. I think that's usually really helpful for the couple.
How'd you get so interested in your field?
That's a good question. I think I had a really good mentor in medical school that he's still kind of my mentor, and opened my eyes to quality life, pelvic floor health conditions, and it just was fascinating. And then in my fellowship, I became very interested in clitoral anatomy, because it was kind of just this like total blind spot in medicine. And so I did a bunch of research on clitoral imaging and associating that with sexual function. And it just became this just like, I'm a curious person. And I was just like, it's so curious. And the fact that it was really examined and understudied kind of made it more intriguing to me. So
that's cool, because so many people don't know anything about sexual health, about the
Right.
body. When I was advertising our sexologist, one of her videos, I had like the clitoris, like I had like the image, and I was like, if you think this is a penguin, then this is the video for you, because with the balls.
Totally. Yeah, and I'm not wearing it today, but I oftentimes wear my clitoris necklace. I'm not wearing it today, but
That's
yeah,
hilarious.
it has, so just to further illustrate, the clitoris has a tip called the glans, and it has a hood that we've already talked about that can cover over the glans, which is not what we want. But it also has two legs called a crura, which are those little wings that go out the side, and then it has bulbs. And if you put this whole thing together, it is exactly the same as the male penis. The only difference is that the urethra goes underneath the clitoris instead of through it like the penis. But otherwise, the clitoris and urethra in a woman are the same exact thing as the male penis. They're just a little bit of size difference, obviously, and where the location of the urethra is. But otherwise, they're the same exact tissue.
So, you just started using LinkedIn Premium. Now what? Well, on your premium company page, you noticed around 7.5 times more page engagement and 5 times more page views. Well done. And now, new clients are messaging you. All because you're using LinkedIn Premium, which helps you get the business growth you want. Think big, small business. Think big. Start your free trial at linkedin.com/premium small business. That's linkedin.com/premium small business.
This episode is brought to you by Polestar. There's only one true way to experience the all-electric luxury SUV Polestar 3, and that's to take a test drive. It can go from 0 to 60 in as little as 4.8 seconds with the dynamic handling of a sports car. But to truly understand how it commands the road, you need to be behind the wheel. Up to 350 miles of range, the 3D surround sound system by Bowers & Wilkins. It's all something you have to experience to believe. So book your test drive for Polestar 3 today at polestar.com.
Yeah, I mean, nobody knows that, so it's a whole new idea for many men, obviously, that the vagina, the vulva itself, is not the sex organ. I mean, it's a sex organ, but it's not the main thing. They don't get it, and a lot of women don't get it. And what I saw advertised, my gynecologist, an O shot. What's that?
Yeah. So an O shot is where they take your own blood. Okay. So they drop your own blood and they spin it down to get just platelet rich plasma from it. So they take out base of the red blood cells and leave like the serum. And then they inject that back into the anterior distal vagina, which is the location of the quote unquote, I'm going to really put it in air quotes, G-spot, which is really just the internal portions of the clitoris, but whatever, that's a whole nother thing. And because then you're sort of amplifying that area, so there's more stimulation.
Oh.
So now you have, a woman can stimulate externally, which is where most women like to stimulate, but also with penetration, there's more sort of internal stimulation as well. And some practitioners will also put some around the clitoral glands. I've seen it done both ways.
It's like plumping it all up.
Right. You're kind of like bringing more nutrients to it again. But we haven't validated this. One of my colleagues actually at MedStar, through a funded study that I did as this other work I'm doing in my nonprofit work, just presented a study looking at the O shot. We thought we would have negative findings. We did placebo O shots and we did PRP O shots. And actually, the PRP O shot did better. So there is some benefit to it. But again, what we really need to do now is study the O shot versus just vaginal hormones, right? Can we just bring more blood flow back naturally? Do we need to, do these other fancy things?
You need to do that versus marital therapy too. And then
I mean, husbandectomies sometimes are recommended. So yeah, for sure. Yeah. I always say to my patients, like, I can't fix a bad marriage with hormone therapy.
Yeah, but when you do get the guy in for, like, if he's coming into here, sometimes you see stuff, obviously.
Oh, for sure.
And he's like not being nice. And of course, there's many situations where the woman's not being nice, but in the situation where the husband's not being nice, then you can kind of see a little bit of maybe.
Oh, totally.
psychosocial part of that,
100%, 100%. And my favorite couples are the ones that come back and now things are blissful again. And, it brings me so much joy. Yeah.
Well, this has been awesome. You know so much. I want to have you back again. We should probably do like a live or something, because nobody would ask me anything. It would all be them asking you, because you know so much stuff. It's great. So you can practice anywhere?
So my telehealth patients are mostly hormone related patients, but we have most of our patients actually do fly in for an exam at some point, because usually there's other things going on, sexual pain issues, clitoral adhesions, other things that we need to actually examine in person. But we do a lot of initial visits virtually and then have them come in for a visit.
So I hope everybody watching this on the Dr. Psych Mom show reaches out, because, Christine, Dr. Vaccaro is a wonderful resource, super smart. Like, you published on I'm so nowhere near research anymore. Like, after graduate school, I was like, this is done, man. Right. So anybody who can maintain a clinical practice and also still be invested and embedded in the academic world is obviously, you're super energetic and smart and everything. So thank you so, so much for coming.
Thank you for inviting me. This was so fun.
It was so fun. And if anybody has any questions, by the way, email me or put in the comments of Spotify, and then I could get Dr. Christine back and answer some other questions at some point, correct?
Yes, I'd love it.
She's got to say yes. She's on the hot seat now, but
I truly love educating women on these platforms, because it can reach so many people and it gives women hope for answers. So I love it.
Thank you so, so, so much. Okay. Thanks, everybody. Bye-bye.